Welcome back to In Time TV's On the Edge, Conversations in Emerging Medical Technologies. I am Dr. Jonas Moses. With me today, Dr. Jennifer I. Lim from the University of Illinois Chicago's Retina Service. And we are talking this hour about optical coherence tomography. Just before the commercial break, we were starting to talk about drusen in the eye related to macular disease. And if we can go back to that slide in just a second, I do want to remind our viewers that you can join the conversation by typing an email to ask@intimetv.com. We do have someone monitoring the incoming mailbox during the shows, and you're welcome to join in with your questions, comments, any opposite opinions, opposing views, and we'd be delighted to air those during the show. Remember, that's only during our live shows at noon on Saturdays. To watch any episodes of In Time TV, you can go to www.intimetv.com and access the archive section. Now back to the conversation, and we did have a slide up, and let's go take a look at that slide there. There you go, and that's drusen and ERM there. All right, and you were talking about the upper left-hand slide.
Right, I was just saying that upper left-hand slide is the older generation OCT, the third generation.
All right.
You see the little ripples of the drusen, but in addition there's some mild motion artifact. And if you look at the slide right below it, you'll see again the little cones, but they look more uniform. There's less motion artifact there. So you can actually see drusen quite nicely. And the slides on the right just show an example of an epiretinal membrane, which is a little bit of scar tissue on the surface of the retina that can cause retinal plication on top of the retina and distortion of vision, not related to macular degeneration, but just an incidental finding in another patient who happened to have some drusen and an epiretinal.
And I'm looking at this slide, and I want to ask you, is that false color imaging there? How is that accomplished?
That's a good point. That is false color imaging. The more highly reflective the tissue is, the hotter the color that's associated with it. So orange and reds are highly reflective. The more cellular components that aren't as reflective, they're blue and green. So it's a false color imaging.
So in that image, the membrane is what's appearing red? All right,
correct.
Great.
The membrane is red and the cells are blue and green.
All right, great. Do we have another slide? Let's see, we're going to...
Slide number 4.
Slide number 4.
And on slide 4, it's just an example of a patient that has macular degeneration with an area of elevation underneath the retina, which is that first black space above the orangish red line. And then the orange-red line is that retinal pigment epithelium, or RPE. And you can see that it looks like a little bump, and that's a pigment epithelial detachment. And
is that a serous detachment? Is there fluid in there?
Correct. Those are areas of fluid underneath the pigment layer and underneath the retina. And prior to OCT, we would get a fluorescein angiogram, and the fluorescein would show us leakage. And we'd have to deduce from looking at stereofluoresceins what area had the fluid. So we would see some subretinal fluid, and then we'd see areas where the RPE is elevated in 3 dimensions. And now, as you can see in the OCT, you can see that with one cut, the area of RPE elevation and the fluid underneath the retina.
Briefly, I want to take a sidestep here and just ask you, how long does a typical scan take?
Just a few seconds with the newer generation OCTs.
And this is accomplished in the clinical setting?
Absolutely in the clinical setting. The photographer can take it, a trained photographer, or you and I could do it, or we could teach one of our technicians to do it.
And it's done through a dilated pupil?
Right, and it requires clear media. So sometimes it's a little bit difficult. If a patient, say, had vitreous hemorrhage, you're not going to get a great view of the retina. Because, again, it's light, so it has to be clear so the light can go in, reflect back, and you can get the signals back.
And I know that...
It's pretty painless, I might add.
Sure, I know that this is low coherence tomography, and which means that it's white light. Is this viable with laser?
You can.
Something that helps drive that in the ultra high?
Right. On the ultra high, using, I think it's titanium and other type of light sources, you can actually get very, very fast scans through there, and then you get ultra high resolution.
Does that help you get
through
challenging media as well? No.
Not exactly. I mean, you still can't get through a vitreous hemorrhage.
I imagine that through a
dense cataract.
A dense cataract or something like that. It's also a problem.
Right.
All right. So we have a next slide here. Slide number
5.
5. Okay.
Geographic atrophy. And this is just an example of how the OCT can actually show you where the areas of thinning of the RPE are,
Once again, RP is retinal pigment epithelium.
Right, and geographic atrophy is probably the most advanced form of dry macular degeneration. That is
the difference between, and that's a good point. We'll leave the slide up here for just a second and talk about the difference between dry and wet.
Right, so dry is basically the earliest form of macular degeneration, where you have sometimes thinning of the retina or degeneration or basically just drusen. And then in about 15% of these patients, they can go on to develop this wet form in general.
And why is it called wet form?
Wet because there's fluid that shows up, there's blood. So it's a colloquial term.
Okay.
And the more scientific term would be neovascular age-related macular degeneration.
Good.
And there are some dry patients who have a very high risk, even up to 85% in 5 years, that they'll convert to wet. So they really should be seen by a retina specialist or ophthalmologist to help them figure out what their risk is.
Now, you just said AMD or age-related macular degeneration, and maybe it's a good point at which to talk just a little bit about the kinds of macular disease that are useful here. So AMD, age-related macular degeneration, cystoid macular edema.
Right.
Is another.
Diabetic macular edema, venous occlusive disease related, central serous. I mean, these are all great applications to use the OCT for.
And are these all typically seen in an older population, or can we see these kinds of changes in any age population?
Pretty much it's useful across the age range OCT because, you know, there are young people who have things like retinoschisis, diseases like that, or retinal degenerations, and you use the OCT to see the structure of the retina in those patients.
I think of retinitis pigmentosa because you can see that in young people as well.
Absolutely.
Yeah. In these populations, how quickly is their vision changing? Someone walks in, they say, "Gee, I notice something, and I'm looking and I'm reading, and I can't. It's kind of blurry." Why is it critical that we have these tools, these things that are going to change rapidly?
The point is well taken. You know, these are patients who one day can be fine with age-related macular degeneration, and the next day they can notice blurred vision,